to the Bare Naked Shrinks.
Hello, and welcome to the Bare Naked Shrinks with me, Dr. Courtney, and my fabulous co-host, Dr. Danny.
Hey.
Today, Dr. Danny and I have the pleasure to host Dr. Erin Harrop, and they are going to be discussing their work on atypical anorexia. Dr. Harrop, them, is an assistant professor at the University of Denver and a licensed medical social worker. Their research focuses on eating disorders, weight stigma, adolescent health behaviors, and patient-provider communication. We're so excited to have them on our podcast today and can't wait to have them tell us all about the amazing research that they're doing. But first, let's get started with our
cake and crap.
Okay, so my cake this week would be going to see Charlie XCX and Troye Sivan in concert on Wednesday. They were at Climate Pledge in Seattle, and I went with one of my good friends, and it was so much fun, and we danced our little hearts out, and it was amazing, and Charlie is queen, and I had the best time. So that was definitely my cake for this week. And my crap, I think probably my crap was just coming home from San Diego after just like such a fun weekend, catching up with like all my friends and colleagues, and getting back after like a trip or any type of vacation is always just like there's a little bit of a bummer to that, because I definitely like miss San Diego and all my friends there. So yeah, I would say that was my crap. What about you, Danny?
Well, I haven't done very many exciting things this week, I don't think, as usual. I mean, I work and then I go home to the children, and so I'm far less glamorous than Dr. Courtney. I will say my cake is I did a new manicure today for fall. I'm really feeling fall, so I did a dark look, and I'm really excited about Halloween. I'm gonna go. Do you all watch Yellow Jackets?
Yes.
I'm gonna be the antler queen.
Love it. Love it.
Because young Natalie is the antler queen. So I'm like, with my new short hair, I can't wait. I'm going to be like the young Natalie. And then crap, I would say definitely coming back from San Diego, but not just because I was bummed. It was like Matt got like jealous or something. I don't even know. It was so annoying. He was like, why didn't you come back earlier? And I was like, because I had to do my podcast with Courtney. And I'm not like jealous of Courtney, but like jealous of the whole weekend.
Sorry we had fun without you.
I know. This is why I always say I wish I liked women, because men are so annoying. But I love him so much, and we made up, and it really helped. We had a good conversation, and we're on a super good page right now. So I would say that would be the crap turning into cake.
Okay, Erin, what about you?
So the crap was definitely dealing with third grade friendship drama this week. My kiddo is in third grade and trying to now I felt like we were at middle school girl level for a hot minute with friendship jealousies and some name calling, and had a nice talk about rumors and all of that loveliness. So
I didn't know you had a third grader too. That's how old Wilder is. And we actually had the same thing. I didn't even think to bring that up.
The gist was some of my kiddos' friends who were not playing with them as much, and then there was some confrontation during recess when they were telling them why they weren't playing with them anymore. And then both of them didn't want to be friends anymore. And, I checked in with the mom, because I know this mom, they've been friends for years, and was like, I heard this. Is that really what's going on? And she was like, oh, I heard a different story. So we both kind of talked with the kids that night and, went through rumors and how we need to tell the truth and be careful what we say about people behind their backs. And, we can make a mistake in friendship, but we need to apologize and make amends. And then, of course, with also third grade delight, they had a talk the next day and worked it out, and now they're friends again. So,
That's so cute.
Yeah.
Talk about a roller coaster.
No, it is. I think this is the age that it starts, Erin, because we've noticed that too. Wilder had a thing this week where he has one group of friends that I would say maybe identify as the cool kids. And then he has one friend who maybe doesn't, but I honestly think is the coolest kid ever. And he kind of feels torn between these two groups. And then there's sort of a bullyish kid in the more popular group who will be like, you're out. You can't be in our group if you talk to so-and-so, the kid who I think is the real cool kid. And so he felt torn between, but then it was hilarious because he was like, well, I kind of already figured out how to get the boss. I'm just going to say that instead of his name, the boss of the friend group. He was like, I just give him Takis and he lets me back in. That's amazing. I'm glad you're learning what works with people.
Yeah.
So what about your cake this week?
My cake, I think I'm going to go with, I had my first like gala where I got to dress up all fancy and I had to actually buy shoes and an outfit, which is not my favorite. I'm a very low maintenance person. And so that was the worst part of it. But getting to spend the night out with my wife and eat fancy food. And I did not dance because the aforementioned shoes were terrible as far as walking around.
Of course.
But
what did you wear?
I wore like a black pantsuit jumper kind of thing. It was super fun. Clothes are always like such a challenge because with my gender, like I don't really love dresses, but they don't make a lot of men's clothes or gender neutral clothes that I feel particularly comfortable in or that fit my body very well. So this was like a good compromise.
Awesome. I will be your stylist anytime. You send me an inspo and I will find you something.
Awesome.
Okay, so now we're going to do something fun, and we're all going to talk about a recent embarrassing moment that we have. I think some people are aware that my new favorite hobby is rewriting lyrics to popular songs about DBT skills, right? It's like where my brain is going every time like a new song comes on. And like I have a notes app on my phone now that's just like song and then like what the updated lyrics are for a DBT skill. It's like kind of aggressive and I'm loving it. Anyways, so last Friday night when we were at Tara's house hanging out in San Diego, we're sitting around, we're chatting, and you know, there's music playing in the background, and all of a sudden, Man, I Feel Like a Woman comes on by Shania Twain. And I'm just like, oh my gosh, damn, I've accessed Wise Mind. Like, man, I feel like a woman, right? And so then I'm like, oh my gosh, the best thing about accessing Wise Mind is the prerogative to build your best life, right? And I'm like, this is amazing. This is gold. And so I've like paused this conversation. Tara, here's my phone, film this. So I stand up. Tara gets out my phone. She starts to film. And right as that happens, her husband walks in and his face is just like, and he is mortified, like absolutely
On your
mortified.
behalf?
Yes, on my behalf. He's like, what is this chaos that I'm walking into? And then he proceeded to just like hang out with us for the next like half an hour and be like, you bitches are crazy. I guess not like super embarrassing, but it was like just really funny. And the whole thing's on video, so it makes me feel.
I don't really feel embarrassment, and I definitely don't feel shame.
Wait, I have a question. Do you not get embarrassed when we talk about the camo Barbie era?
No.
Okay, just wanted to check.
No. Yeah, you can be like, you literally could say anything that I've done in my past. I was just on one of my friends' podcasts. He's an ABDL daddy, and he is like, do you know what that is? Adult baby diaper lover. How do people not know this? We met in college, and that's when I was in my very much camo Barbie / church era. And I tried to evangelize him. And I didn't remember doing that because I'm like not religious now. And he was like, you literally told me because I was Jewish, I had a place in heaven. And I was like, okay, I'm a little embarrassed about that. I'm a little embarrassed about that. And he was like, I just think it just shows how full circle you've come and the fact that our friendship has endured all of this. And now he's like, look at me. I'm an ABDL daddy sitting in your office asking you if you have any children's books I can borrow. And I'm like, that's where we've come.
Okay, Erin, what about you?
Okay, here's my two disclaimers. One, I'm one of those people who gets really involved in like a TV show or a movie. So like at the end of the movie, if like people are clapping for someone winning an award, like I'll forget and I'll be in the moment and I'll just start clapping. If they're like standing for the bride in a wedding, like I once stood in the middle of a movie theater by accident, right? Like it's really mortifying. And then like you pair that with the therapeutic skill of like, when we're with clients, we're taught to like mirror a little bit and mirror some of the body language, Right? So anyway, I'm watching lesbian TikTok. And my wife is sitting next to me, and it's like one of those like videos where they're like masked lesbian talking about like hot people in Hollywood. And like she starts doing these like come on lines, and I'm like interacting with the screen, like, yeah. Like and my wife all of a sudden like looks at me and she's like, oh my God, Erin, are you hitting on your phone? And I was like, yes, I am. I am hitting on my phone right now. And now I'm mortified. So thank you.
Erin, actually, this story makes me obsessed with you. Like, how joyful of a moment to just be in it that hard.
I want to feel that like passionately about when I watch something. Like, how one mindful.
Yes, one mindful.
Later, I was like, man, that's nice that I wasn't like super distracted in that moment. I was like there. I was in it. Maybe like not in the same way next time, like at the, like sitting around the table while we're all hanging out, but it's cool.
Okay, so let's get on to the educational portion of the day where Erin's going to discuss their work on atypical anorexia.
Rebel girl.
So tell us about your work and introduce us to the topic.
Yeah, so I focus in on atypical anorexia. And really, when we're talking about atypical anorexia, we are talking about anorexia, period. For some bizarre reason, which I think is stigma, we have this different label for anorexia when it manifests in someone in a larger body than when it manifests in someone in a smaller body. One of the reasons that I think is kind of weird is because we don't have something like gay anorexia or male anorexia, right? Like we don't, even though gay clients, trans clients, male clients have different treatment needs than other clients, right? Even though there are some differences with like how this might develop or what might contribute to it, or even how we treat it, we still don't kind of pick this one physical or other identity characteristic about someone and then give it a whole new name just because of a person's identity. But with the case of atypical anorexia, if someone has anorexia, if they're restricting and they have the cognitions that go along with it and they experience the body changes that go along with malnutrition and starvation, for some reason we give it this name of atypical anorexia. It's also a little misleading because if you look at the numbers in the population of people who deal with anorexia and who deal with these symptoms and behaviors, there's actually more people who have anorexia in larger bodies than people who have anorexia in smaller bodies. So it's not really atypical at all. It's just that because of how our minds work and how we associate body size with food and those kind of stereotypes, like it's basically our stigma that makes us think of it as weird or abnormal or atypical.
Maybe we should call it A-Stereotypical.
Yes, yeah.
That would be the best change. Like, let's start that. Let's start calling it that.
It's A-Stereotypical anorexia.
Mm-hmm.
You heard it here first on the Bare Naked Shrink.
So anyway, we're talking about people with anorexia who restrict, who go through experiences of significant weight loss. That's a whole other topic that we can get into on another show. And what happens for these folks, because of the stereotypes in society where we just automatically assume that first of all, that everyone pretty much universally is trying to lose weight, right? Like you can be in a thin body and, you can lose weight when you get the flu and people can be like, oh my God, you lost weight. What did you do? It's like, well, I was just like sick and puking my guts out for the last week, but thanks. So we have these assumptions regardless of body size, but particularly for larger body people, that if they lose weight, that's always a good thing. And so what ends up happening for folks who have atypical anorexia is that when their eating disorder starts to get worse, when their symptoms and their behaviors increase in intensity and increase in frequency, and that weight loss becomes more noticeable, rather than having people be concerned, like, oh gosh, we can all think of the friend that we've had, we can think of ourselves, maybe the patient that we've had where, we notice them getting a little thinner. We notice that they've skipped out on some hangout times with friends. They've skipped out on some meals. They've always eaten before they've come. And with that friend, when they lose a little bit of weight, we might get a little concerned. We might want to check in on them like, hey, are you okay? What's going on? But for the larger bodied person, and I'll use the term fat here in like a neutral or positive or reclaimed sense.
I would love if you could define that movement of retaking back the word fat.
Yeah. So this is something that we do in a lot of different spheres within society, particularly in groups that experience stigma or marginalization. There might be a word, for instance, the word queer, right, that has historically been heaped with stigma and denigration. It's used as a slur. And then that sometimes that marginalized group or that group of folks who experience the stigma claim that word back and say, you know what? This is who we are, and you can't hurt me with this word anymore. And so I'm here, I'm queer, get used to it, right? And in the same way, that's happened with the word queer. It's happened with the word Chicana. It's happened with multiple words that have been previously used to kind of denigrate or make someone feel bad about themselves or their identity. And then that group has kind of risen up and say, no, we're taking this language back and we're reclaiming it. And so within the fat liberation movement, which is a movement that pushes back against weight stigma and stigmatizing people for how large their bodies are, within that movement, the word fat is one of those words where people have said, you know what, this word was used by bullies my entire life, and now I'm reclaiming it. And yeah, I am fat. Yeah, my body is fat. And, kind of what are you going to do about it? Like, it's just here. And so that is a word that I use to describe my own body. That is a word that other people use to describe their bodies. And I will say, if you're a thin person, be careful how you might experiment with using this word, right? And so it's not that thin people cannot use the word, because you absolutely can. Just make sure that when you're doing it in a neutral or positive way, and try it out. Like Santa Claus is usually portrayed as fat, right? On the internet, everybody loves cats who are fat, right? So we can start to practice saying it. And as we do that, it can lose a little bit of its like stinging power or its hurting power.
I love that. Thank you. Thank you so much for spelling that out.
So what I was saying basically is that when we have, the fat kid or the fat girl in high school who all of a sudden starts losing weight, maybe even really quickly, oftentimes what's said to her is like, oh my God, I don't know what you're doing, but keep doing it. Or you look great. Or, they might go to the doctor and the doctor might even comment on it and say like, wow, like, your weight is looking much better than last time. And so for the difference here in the eating disorder experience is that a person could be having the same thought processes and the same feelings and the same behaviors and physical symptoms. Their hair could be falling out. They could be experiencing, brittle nails. They could be having purging behaviors that go along with the self-starvation and all of the physical symptoms that come from that. They could be tired and have headaches. They could miss their periods month after month after month. And rather than someone expressing concern, all that they get is affirmation. And so what they're really saying is like, we would rather you have an eating disorder than look the way you used to look. Mm-hmm. And for someone who's dealing with all of those feelings of body shame, that just entrenches the eating disorder even more. So within atypical anorexia, while it is the same disease, in my opinion, and it's the same process, the same feelings, there is this like added layer of like how stigma interacts with people who have atypical anorexia, because all of a sudden, instead of society affirming recovery and health for you, society and your peers and the medical community and even your parents might start to affirm your disease over a state of nourishment and health and balance. And this could be why, when we look at some of the studies that compare thin anorexia to larger bodied anorexia, why we actually see higher cognitive symptoms and emotional symptoms for people with atypical anorexia. So their scores are disordered, but they're actually more disordered. And that suggests to me that that might be that like added layer of stigma that comes in there because of society. And then when we also look at, well, you know, because people will say like, well, if they're fat, then they can't be missing too much food, right? Right? Like they can't be starving that badly or they wouldn't be in this fat body. And the reality is that any size body can experience malnutrition when it's not fed, period.
Which is like why people with gastric bypass surgery, you know, have to take all these supplements and eat this very specific diet because, yeah, they're in a bigger body and they are starving themselves. So, of course, they're going to be malnourished, you know?
Exactly. It's why when starvation or famine hits in a certain area, it's not just small-bodied people that are impacted by that famine, right? Like this is, or by that environmental crisis or that social crisis or by that war. Like everybody, when we don't have the nutrition that we need to sustain us, is going to feel those effects of malnutrition. And the data shows that out. So we know that anorexia is the most deadly of the eating disorders that we see. And it's one of the most deadly of the psychiatric disorders, period. And those same things, those life-threatening consequences, that electrolyte imbalance, the orthostatic hypotension, which means like our body's losing the ability to regulate our blood pressure when we sit up or lay down or walk around or change altitude, hypothermia, all of those things are seen in patients who are at higher weights with anorexia at the same commensurate rates as we see that in lower weight patients. And there are some things that are a little different. For instance, amenorrhea, losing your menses or your period. Sometimes that occurs in different frequencies, but patients of all weights also experience loss of menses. And same thing with things like osteoporosis, which is tied to our hormones and our fat stores that are in our body. That is also something that people with atypical anorexia also see, though they see it at slightly different rates. So oftentimes, though, I feel like people think of anorexia in a higher weight body as less serious or less physically compromised. Often people will talk about, well, we need to help them, you know, heal their emotions and their mind and their body image, but they might not even think about what kind of weight restoration or food and nutrition this person needs. And indeed, in many of the treatment centers that I've talked to patients from, they were not actually put on weight restoration plans when they went into treatment for their atypical anorexia. They were put on maintenance plans instead, and some were put on weight loss plans, even though they were in there for a primary symptom of restriction. So all of this makes recovery complicated. It makes the disease very complicated. And essentially you have a patient who's getting all of these contradicting messages about how to recover from their eating disorder. And it makes the journey very long. And honestly, within our treatment system, from many of the patients that I've talked to, our treatment often makes them worse, or it solidifies their eating disorder, which is, you know, as a eating disorder professional, like the exact opposite of what I want to be doing.
I wanted to add one thing about the brain, you know, or the cognitive effects, because I love biology. So the reason, some people don't know the reason that you get these cognitive effects are because the brain actually atrophies. So our brain, our neurons communicate with one another via myelinated sheaths along the axons. And when you starve yourself, the body actually takes fat away from the brain. So it is not communicating. And 10% brain atrophy could be 1 to 2 standard deviations of intelligence. And so imagine in your job or at school how much that's going to affect you, or driving. I've had patients who get in car accidents because they just aren't able to process fast enough. So there's a lot of dangers to that. And it happens whether you're in a small body or a fat body.
Yeah. I think too about memory, right? And how like in the moment, and oftentimes our patients with eating disorders can be highly competent in many areas of their life, academically, at their job, professionally. But I've definitely seen it in patients. I've actually, as somebody with lived experience of these disorders, I've seen it in myself where I can excel academically and not remember a thing of what I learned, or go through a period of that intense starvation and realize, you know, I had this experience going back to my college campus, where I went back to my college campus and I was like walking around. I lived here for years and I was like, I remember where the gym is, Right? My partner at the time was, like, well, where's like your cafeteria? And I was like,
Wow.
like, and that, like, our minds and our memories can be just so fundamentally impacted by this. And maybe at the time we think we're fine, we're passing, we're getting the grade. But that long-term impact on your body, on your cognition can really take a toll. Part of my work is talking with patients who have this diagnosis. So I do a lot of interviews of patients. I also ask them to draw their experiences, like to think of a moment and kind of go back to that and draw an image of what they can remember about it or something that represents it. And by far, some of the biggest things that I hear from patients is just how much other people's opinions about their bodies and society's opinions about their bodies and their parents or their medical providers, how much that not only motivated and kind of triggered the disorder in the first place of just feeling like my body's wrong, it's too large, I need to fix it, or, worry about if it keeps growing, what happens if maybe I'm not in a larger body yet, but maybe my doctor told me like, oh, your BMI is kind of creeping up. We need to be careful about this, right? How much just that fear reinforced their eating disorder and their disordered behaviors and made it like basically kind of made this disguise. Right. Eating disorders are already tricky. They're already hard to identify and diagnose. And then when you add this extra layer of kind of stereotypes and stigma, and, if we all were to just think in our minds right now, like, think of a person who has anorexia, right? Or like picture what that looks like. Like, I study this. I got my PhD in this, and I'm still pulling up an image.
Yeah.
That does not represent someone in a larger body. I'm still, even though that's the most common manifestation of anorexia, if we look at the population level data, my brain is still pulling up a very different image. So those stereotypes just harm and make it difficult to identify and then get people treatment.
I appreciate you acknowledging that, Erin, because it makes me think of patients that I have that when like they are focusing on recovery or something and they still have like negative thoughts about their body or food or things like that, and they get really frustrated that it's there, and they're like, I'm recovered, I should not have these things. And I think it's really important to highlight that dialectic of like, we can know one thing and still like automatically feel or think of another thing at the same time. I have a couple of questions. The first one, so you're talking about treatment for individuals with atypical anorexia and how oftentimes, I think more often than not actually, these individuals go to different treatment centers and they do more harm than good. And I think it's really challenging, I would imagine, for people that are not in the field to identify one where they can go to get treatment that will be HAES aligned or fat positive. And do you have any thoughts on like, what do you recommend individuals in larger bodies that have anorexia do if they are seeking help? Like, are there resources available? What would you recommend that they do and to seek the treatment that they need for their experience that's going to be helpful? So that's my first question.
And like questions to interview a therapist, like if they are only wanting outpatient at, to get started because maybe they're afraid or they've been systematically like mistreated. What kind of interview questions would you ask a clinician?
Yeah, I would absolutely ask a treatment center or a therapist or dietitian even too. Same thing. One, you can just ask them like, how do you treat clients who have atypical anorexia? Like, what does their treatment pathway look like? And you can specifically ask also about how they do weight restoration for patients with atypical anorexia. Because if there's going to be language in that, like if they're responding and they're saying, well, sometimes our clients with atypical anorexia don't even need to gain weight. All we need to do is stabilize them. Like if that kind of language is coming through, I would say that's a huge red flag for me. Because if somebody has anorexia and they have lost weight and they have been that weight suppressed, to assume that we can just stabilize them at the place that their eating disorder brought them into treatment is a huge disservice, right? We might not know where their body will stabilize, but I think we can absolutely count on that person needing to have weight gain. And that could be like up to and beyond their weight prior to their eating disorder. We don't know. And we won't know until we see what does their cognitive rigidity look like, right? Is that easing up at all? What are their labs looking like? How are their blood pressures and things like that? And so treatment centers that make either promises that a patient is not going to gain weight, or that, and some treatment centers, like any promises of weight loss, I think that's another giant red flag, that don't see weight restoration as part of the process for every patient with atypical anorexia. I think those are red flags that I would have.
What about like when obviously if they are trying to lose weight, they have their own internalized weight stigma and bias. This is my answer, and I want to ask you as the expert what you think of this. I always say I am here to treat the symptoms, not your body and not your body weight. So I don't know what your body's going to do. It may go up, it may stay the same, it may go down. I'm here to talk about the symptoms that are causing you distress, and don't give a flying F about the number on the scale. Like, because I feel like I have to balance that line, because I also don't, I want them to come see me because I am pace aligned, and I want them to trust me and not be afraid of weight gain. But I'm hoping by the point we get to whatever the weight varies, that we will have treated the symptoms and the cognitions to a point that can be acceptable.
Yeah. I think and this is something that a lot of HAES providers struggle with. Like, if a patient knows that they might gain weight, like, will they even begin treatment? Right. And that is really challenging. And I think we need to have honesty with the fact that this is a likely probability, right? Like, and I think when we're talking with people, and Danielle, I love how you framed that, right? Like, we are going to focus here on maximizing your health and getting your symptoms to decrease and your distress around things to decrease. And as we're doing that, we can measure your body all we want. We can take all the labs, we can take all of the weight history that we can, but there's a lot of things that we don't know about how your body's going to recover. And particularly if people's restrictions started young, if people were put on diets really young, we might not have a lot of good growth curve data beyond the age that those diets started for the children, right? So Dr. Peebles and Dr. Mulheim, who some of you might know, they're in the process of working on a paper that's coming out on how to give patients, and especially parents of patients, of younger patients, like a better idea of what they might expect in the recovery process, of like where physically bodies typically need to go when they've been severely malnourished and we need to rebuild there. But yeah, I think making sure that patients know, like, because your starvation and your restriction is so extreme, as we give gentle nutrition back to your body, and as we go through this refeeding and nutritional rehabilitation process, there are likely going to be changes in your body. And what we want to do is help you cope with those changes and get you to a place where you're healthy and you're thriving. And healthy doesn't necessarily mean thinner. Right? Healthy means that you're restored, that you have the energy that you need to do things, that your body has the building blocks for muscle and myelination and all of these things that we need in order to function. And because I think part of, Danielle, what I'm hearing you say is, like, when patients hear that, they might hear, oh, they're going to make me fat, or they're going to make me fatter. And I'm going to say here, like, ooh, let's like pay attention to that weight stigma popping up, right? Like, I think things to emphasize to our clients is, like, this is a deadly illness. And whether or not, like, you recognize it or other people in your life recognize it, the malnutrition that you're experiencing from this severe restriction, like, that's the problem. And we need to fear your eating disorder far more than we fear what your body looks like now or what it could look like. We need to focus on restoring your body and restoring your mind, because living in the hell of an eating disorder mind, like, that sucks. Like, I don't even know how to like that is torture. Right. And that's what we want to help our clients step out of. And even the thinnest client that we have, that eating disorder brain is torture, right? And so that's what we're focused on in treatment. And some of that treatment, some of that medicine is food. You know, after years of restriction, after decades, many times the people with atypical anorexia are on the older side, right? When we identify them, there's also just more years that you can be old than years that you can be young. So, you know, keep that in mind, right? But like oftentimes people who are dealing with atypical anorexia have been struggling with their eating disorder for years, if not decades, and rolling all of that back. One, that's a ton of mental programming and deprogramming that needs to happen. And two, we just don't know. We can't predict how someone's body is going to react. So I think like promises that someone will lose weight, definitely a red flag. But promises that like your body will change, because it will change, right? It's going to get healthier. You're going to get stronger. You're going to stop fainting when you stand up. You're going to have energy sustained throughout the day. Your memory is going to improve. You know, your hair is going to get different. Like there's all these things that will change. And as far as weight goes, we don't necessarily know how that is going to look.
So this kind of brings me to my next question. And I think this is something that I've talked a lot about with my team and my colleagues about, and kind of how to navigate this, is when we're working with individuals in larger bodies on this eating disorder recovery, the fact that weight stigma, anti-fat bias exists in this world. And even if we're working on the internalized weight stigma that patients experience, as soon as they leave our office, they're living in a sociocultural environment that's not built for their body in a lot of ways, right? And we're all constantly exposed to messaging around the need to lose weight, the need to be fit, whatever, restrict our diet. In recovery, then, they're recovering in an environment that is telling them repeatedly, daily, that your body is not okay the way it is.
Yeah.
And that's a very real experience, right? And so that we have to acknowledge. Where I'm going with this is, obviously as clinicians, like we can validate that experience. But I think where I've struggled is, what do we do beyond that? Because I think obviously validation, and then, you know, as a DBT therapist, I'm like, well, we can radically accept that this exists, but it doesn't feel like that's enough. Obviously, like we can work on skills to cope with the environment, right? That's important. But also, yeah, I think I just have judgments too about then like putting the extra work on the individual that's suffering. But yeah, how do you navigate that? What do we do with that? Because I don't have hope that our culture is going to change anytime in the near future. So yeah.
I am so glad you asked this. And I'm also thinking, I want to even expand the conversation now from just folks with atypical anorexia to folks with other eating disorders who might be like lower weight anorexia, because many people with low weight anorexia recover in their process of recovery, they recover into bodies that are now more stigmatized than when they were, you know, a size X. Right. And so they've experienced whatever weight gain in recovery. And maybe at the beginning, people were like, oh, you were a little scary skinny before. I hear my big quotes here. But now you're looking a lot healthier, right? Like these are all the terrible things that we hear. But then there can be a point when that person who's recovering from thin anorexia, like people start worrying like, oh, are you recovering like too much here?
Totally.
Like, are we going too far in the other direction? Right.
Like when parents,
the parents, I feel like, not to blame or shame, but like in FET, those comments.
Parents.
Anyways.
I love parents, but oh gosh. And like this fear is coming from one, the hysteria and the fear and the anxiety that our whole culture has around higher weight folks and health, right? So, and it's coming from a lot of misconceptions about the connection between weight and health. And it's also coming from parents just really wanting the best for their kid, wanting them to have the most social opportunities, academic experiences, opportunities, career opportunities, all of those things. And none of those things, in my opinion, are worth a life-threatening eating disorder. None of them. But I would say, yes, we can validate, and I'm glad that you said, like, it doesn't feel like enough, right? To just teach people how to cope with the fact that, yes, weight stigma exists and it's awful. And how do we cope with that? Some therapists that I really admire their work, they said, we're really doing a disservice to clients if we're teaching them to adapt to the oppression and stigma within society.
And that's what,
like,
and that's
if that's
essentially
our
yeah.
goal in therapy, then we can teach people to cope all day long, but then what? Right. And for some of our clients, it's not just weight stigma that they're dealing with. They might be dealing with racial stigma and racism. They might be dealing with transphobia. They might be dealing with homophobia. There's all of these isms that can converge for a client. And just saying, like, oh yeah, the world sucks, it's not you, keep at it, like, that feels like woefully insufficient. What I would say in this situation is that we actually need, and this is where I'm going to get, a little bit more radical and more controversial than I've been, but we actually need treatment to engage, like, more radically with these isms, right? Like, and not just be about, like, thinking about and reflecting and understanding my identities and this place in the world and how the world is messed up, but also, like, how do we move from that place of understanding and that place of grief and that place of the system can't change and it's so big? How do we move from there to a place of action? Another leg of the research that I do is around support groups for people in larger bodies who are dealing with disordered eating and internalized weight stigma, that feeling of, like, I'm bad because my body is big, or because my body is bigger. And one of the things that we found in our work with these groups is that it's not enough to just teach people how to recognize weight stigma, how to understand how pervasive it is in society, how to be able to say, like, oh, I see it at the clothing store, I see it at the doctor, I see it, in people at school, I see it at my work. But if we just leave people in that place of, like, I understand it, I know it's messed up and it's everywhere, what can really happen for our patients is that hopelessness can set in, demoralization can set in, and this place of, like, oh, well then, because if it's just hopeless and it's always going to stay the same, then, like, do I really want to live with this pain, right? That can be the conclusion that our clients come to, is like, I don't think recovery is really worth it, maybe at this point. But that's where therapeutically we have to have an inflection point, and we have to be able to say, like, I'm trying to remember the exact term for it, problem posing and identifying contradictions. So problem posing, so this is referencing some research that's been done on critical consciousness raising from an anti-racism standpoint. And they talk about, like, these two steps that go along together. Problem posing has to deal with understanding the breadth of the problem and how ingrained it is and how messy it is. So if we think about weight stigma or diet culture, we think about, like, just like we see it everywhere. We can recognize when it happens, right? We know that when we go to the doctor and the doctor just gives us a weight loss recommendation without even exploring our eating disorder history or, any other mechanism, like, we can say, like, that's weight stigma. So that's the problem posing. And that's important to recognize where it is. Identifying, and it's also this identifying, like, this is a huge messed up system of discrimination and stigma, and it's not going anywhere. It's here to stay, right? And then we start to look at identifying contradictions. And these has to be done kind of hand in hand. And that's where you start saying, like, where do I not see this? Right. So this is, we can draw on some of our DBT skills here, right? Like, when is this not true? Right. In what, who do I hang out with where weight loss is not the center of the discussion?
Totally.
Right. Like, who are the friend groups? Cause, like, I can hang out with, like, friend groups where, like, calories and working out and whatever, like, that is brought up on the daily, but, like, who are those friends where we're not talking about it? Right? Or where are those spaces? Where do I feel like I can more be myself? Maybe it's at a queer club and you're dancing and you're seeing a whole bunch of different body types recommended. And maybe it's at some of the queer clubs, but not other of the queer clubs, right? Where are the places, where in sports do I go where like my strength and like, you can't see my arms, but these are some like big muscular arms. Like, where do I go where that's celebrated? Right? As opposed to being like, oh, you don't have access to femininity because of your body. Right? So like we start identifying those contradictions. I've always stuck out because of the size of my arms. Like even when I was in a very thin body, I had like great upper body strength. And so like, where are the places where we can like lean into those exceptions in society, and maybe not just where are the little changes happening, like, okay, this is a safe friend or this is a safe spot, but also like systemically, where is change happening? Right? Because changes are happening. And if, you know, Danielle, if you think back with me to like 1999, like in high school, or 1998 in high school, like the conversation around body image right now is really different.
So different.
And so like it is happening, right? Like it feels like, okay, we just get, you know, for every diet that goes out of vogue, there's like a new one that comes in. But like people are changing, people are noticing. And like we have that boomerang effect, right? Like heroin chic's coming back in. I don't know, there was some articles about that, but like we have more suspicion of it now, right? Like we know, like, oh, this wasn't so hot the first time. I can't imagine it working out well the second.
So I'm just going to say this is going to be our longest episode yet. And I think that is because the like passion we have for disseminating this information that is extremely undisseminated. That's not a word. And I am just so excited to share this with people. Like, this is incredible. And this is the voice that needs to be heard. And yeah, I have so many more things I want to say, but I'm going to let Courtney ask like one personal question of you, but we're definitely going to have you back. Season 2, part 2.
Interview the expert.
Erin, why don't you tell us a little bit about like where you came from, how you grew up, and how you got into the field?
Yeah. So I come from Seattle, actually, Dr. Courtney.
What? I didn't know that.
Yeah, I only moved out of Seattle to come here for this job. But yeah, I grew up there, and I came into the family of 4. So I was an oldest daughter, which we know how that goes.
Me too.
And I love it. I love my siblings. I love them. But yeah, definitely that kind of overachiever perfectionist self, and really kind of stumbled into the field just from my own life experience of having an eating disorder from a young age and struggling to get treatment, and running into that place as a young adolescent where even though I was experiencing low weight anorexia, it was still like not the lowest weight to like strike all the alarm bells for like the medical providers and things like that in my life.
Like you're not that sick or sick enough.
Yeah. And we were uninsured. We didn't have mental health parity back in the 90s. There were all these things that worked against me getting treatment. And so, yeah, I wrote my high school college essay on like, I want to change eating disorder treatment for the world, right? Like that was what I wanted to change about things, was like making this more accessible and more accessible for everyone. And while I still had a ton of weight stigma at that point in time, through my own journey of recovery and recovering from a thin body into a fatter body, and realizing like, hey, if I'm going to stick with recovery, if I'm going to have a shot at enjoying my life and living a life worth living, then I'm going to have to make peace with the fact that I'm not the size that I was in my illness anymore. And if I want to be able to like have a child and finish school without having to take a freaking another medical leave, like I'm going to have to make peace with my body as it wants to recover. And so, that was kind of how I came here. And that was also how I came into my dissertation topic, was just reflecting on, because I was eventually able to access treatment in a thin body. And then I, like many of us, relapsed and did not make it like that first time. And so I had to return to treatment in a body that was larger. And I like that was such a poignant comparison for me of how I was treated when I was thin versus in a larger body. And so that was really what I started diving into like, why did that happen? Like, I haven't changed. I'm still the same person. My eating disorder hasn't changed that much either. And so that was really how I kind of fell into this work, and realizing that it wasn't just me. Like, I wasn't like one weird person, that this was actually something that I was seeing over and over in our treatment spaces.
Wow, that was really inspiring to hear. And I loved that you said that, like, being in the body that you're at now, in a larger body, that has been where you've been able to build your life worth living and find that. So the DBT therapist in me is very excited to hear that. Erin, Dr. Harrop, it has been absolutely wonderful to have you on our podcast today. I feel like I've learned a lot. I've really enjoyed our conversation, and I can't wait to have you back again to continue this conversation. So before we wrap up, do you want to tell us a little about our homework? You better work.
Work it, y'all.
You know, I was trying to figure out what I would recommend for this, and I asked a friend, actually. I was like, how do I sum this up? And he gave me the suggestion of try not concern trolling. And I don't know if y'all know what concern trolling is, but
I don't.
You don't?
Yeah.
Okay. Concern trolling is when you see a larger bodied person and you're really concerned about their health, or you feel like you have to say something because you're concerned about their health. In the fat world, we call this concern trolling, because usually it has to do with weight loss. And so it's just a challenge for you to notice concern trolling. When does it happen? When do you see people, parents, medical providers, strangers on the internet who do not actually know you or care about you at all? Like, when do you see concern trolling happening? And then, like, how can you just zip it instead of saying the thing, right? Like, how can you just like not say, just, no, you don't have to be concerned about someone else's weight. That's actually not your concern at all.
Not at all.
So I was thinking, like, let's see if we can notice it. When does this happen?
I love that. I'm going to post a handout about that for the homework, about how do you know if you are concern trolling and how to stop doing it.
I'm worried about you. Like, I'm just worried about your health, or I'm worried about her future, whatever it is. Like, just
So not necessary. I love that.
Let's be worried about mental health, and we can still be worried about physical health, right? Like, we can be legitimately invested by affirming fat people being nourished.
Right. The dialectic of being mentally and physically healthy.
Both can be true at the same time.
Mm-hmm.
Who knew? Oh, I love dialectics. Well, that wraps up our episode today. So please make sure to go to barenakedshrinks.com to download your weekly homework. Stay tuned for our next episode, The Gambler, with Dr. Kelsey Hagen, as we discuss decision-making and risk reward in individuals with bulimia nervosa. If you like what you've heard or seen so far, please follow us on Instagram, TikTok, and YouTube. And please rate, review, and subscribe to the podcast. Talk soon.
Bye.
See y'all next time.